It's Mari McInerney from Croaky here, and we're at the APNA Primary Healthcare Nurses Conference in Brisbane. We've just had a breakfast session, which is ironic somewhat. I'm talking to Dr. Peter Collins now about adult malnutrition. Peter, could you just introduce yourself, say where you're from, and the work that you do?
Yeah, sure. I'm a senior lecturer in nutrition and dietetics from the School of Exercise and Nutrition Science at Queensland University of Technology in Brisbane. Also a visiting research fellow at Princess Alexandra Hospital, where we do a lot of research on nutrition support and malnutrition in particular.
Now, you leapt at the opportunity, you said, to come and talk to a bunch of primary healthcare nurses. Why is that?
Yeah. For a number of reasons, mainly because most of the malnourished patients that we see actually are in the community. So we identify them in the hospital because malnourished patients are more likely to be admitted to hospital, but they don't stay there very long. So we've done research at Princess Alexandra Hospital, for example, looking at malnourished COPD patients, and over half of them are there for less than a week. So whilst we can identify them as malnourished in the hospital, they spend the vast majority of their time in the community, and that's where community practice nurses can have a real impact in not only looking for malnutrition in that patient group, but starting first-line nutrition support.
So, talk about the extent of adult malnutrition. How bad is it, and what are the causes, the predictors? Because postcode, you said, was one of the main ones?
We've recently published data in the International Journal of COPD where we found that postcode was a strong predictor of whether COPD patients were at risk of malnutrition. So that was in UK patients. The causes and consequences, the causes of malnutrition in elderly patients is really complex. It's multifactorial, can be linked to deprivation, budget constraints, social isolation, dentition, physical function, the ability to acquire, prepare and consume foods. It's very complex, and again that's where practice nurses can come in, because having that clinical judgment, noticing that patients' wedding bands are loose, their clothes are not fitting as well, their dentures are slightly loose, they're a bit low in mood. These are all things that might not necessarily be picked up by a screening tool, but an experienced clinician and practice nurse will be onto them straight away, and knowing that that's going to predispose someone to be at risk of malnutrition. And
interestingly, you did say that the physiological factors actually weren't the most, but it has a massive physiological toll, yeah?
Yeah, it's anorexia of aging, we call it. So there's a lot of physiological adaptations that occur when we age that not only impact on the likelihood that we'll lose weight, particularly fat-free mass, but then our ability to regain any lost weight with refeeding. So even if we give elderly patients adequate amounts of nutrition, sometimes it's difficult to get them to regain weight that they've lost. They'll often regain the weight as fat mass instead of muscle mass. So nutritional support in combination with exercise is a lot more effective. Yep.
And so therefore, you said there were some studies too that really showed direct links actually to earlier deaths as a result.
Oh, absolutely, yep. We've shown that just down the road at Princess Alexandra Hospital, the patients that are at risk of malnutrition have a poorer survival than those that are not at risk of malnutrition. There's been studies in the Netherlands as well that have shown if you can get the patients that are malnourished to regain their weight, so they're no longer at risk of malnutrition, their survival improves. And the big thing that we're interested in is quality of life as well.
So you talk then that the community is the place really where we can take action, and as you said, it's like, I think the average is 4.7 days in a hospital after an acute admission. So what are the things that work?
Screening, looking for it. If you don't look for it, you won't find it. And then it's just identifying the nutritional treatments that you can implement. So there's lots of education leaflets, high energy, high protein diets. And then in those patients that you find that are at high risk of malnutrition, refer them to a dietitian.
And given though that you said it's a lot of non-physiological things that actually affect or bring about malnutrition, I mean, can you solve poverty? Can you solve depression? Can you solve isolation?
No.
What do you do about those factors?
So practice nurses, dietitians, occupational therapists, social work, physiotherapists, it's a complex condition that cannot be treated in isolation by one healthcare professional. It needs to be treated by multidisciplinary team, multimodal nutritional therapies. It's the only way you're going to treat it effectively.
And a final question, because as everyone's pouring out for the plenary this morning, Australia seems to be lagging a little bit behind on this?
No, there's a lot of work being done, particularly in Queensland. There's a lot of really experienced dietitians at the Royal Brisbane, Prince Charles Hospital that are leading research on this around simplifying the process of identifying malnutrition and initiating treatment in inpatients. So I think they're publishing that research this year, so watch this space.
Okay, watch this space. Thank you very much for your time.